Welcome to this video entitled, Stroke and Infection Tuberculosis, Brucellosis, Syphilis, Lyme disease and Listeriosis. Neurological complications may occur as sequelae of systemic infection, but can be a presenting feature with certain pathogens. An association exists between ischemic strokes and infection, with a number of proposed mechanisms by which vascular disease develops into central nervous system (CNS) infections. The pathophysiological mechanisms may involve vasculitis, affecting primarily the vessels at the base of the brain in the setting of meningitis, an immune-mediated para-infectious process leading to vasospasm or thrombosis, or a hypercoagulable state in combination with endothelial dysfunction resulting from activation of inflammatory and procoagulant cascades. Patients with neurotuberculosis, neurosyphilis, neurobrucellosis, and neuroinvasive listeriosis can initially have meningitis which may be asymptomatic, but can progress to a chronic form. Cerebrospinal fluid (CSF) analysis is notable for lymphocytic pleocytosis, high protein content, and low glucose levels, and hence is a more sensitive guide in diagnosis, treatment, and cure of the disease. Stroke is a serious complication with CNS infections and is clinically indistinguishable from a non-infectious etiology. Proper management requires a high index of suspicion, prompt recognition and early initiation of appropriate therapy, given progression to devastating neurologic outcomes. We will now take a closer look at neurosyphilis. Neurosyphilis is a globally endemic disease caused by the Spirochaete treponema pallidum. With the development of penicillin, there was a decline in the incidence of syphilis, followed by a resurgence since 2000. Treponema pallidum rapidly invades the CNS early in the course of infection, though most patients remain asymptomatic and the infection is cleared from the CNS. Symptomatic neurosyphilis may occur at any stage of disease. And now we will look at the pathogenesis of neurosyphilis. Treponema pallidum invades, usually following sexual activity through small breaks in the skin or intact mucosa, manifesting later as a chancre at the site of infection. The bacteria then rapidly disseminate to virtually every organ system. CNS invasion occurs quickly, though the majority of patients remain asymptomatic. Infection produces a vasculitis, leading to endarteritis of the large and medium-sized vessels. Obliterative endarteritis is characterized by fibroblast proliferation in the intima, a thinning of the media, and fibrosis of the adventitia. This inflammation leads to thrombosis and infarction. Infection with treponema pallidum may also directly involve the brain parenchyma, causing frontal and temporal lobe atrophy. Next we will look at clinical features of neurosyphilis. Early symptoms of neurosyphilis include headache, vertigo, and insomnia, typically with a sudden onset. Stroke symptoms are directly related to the areas of infarction, with the middle cerebral artery, abbreviated as MCA, and basilar artery, abbreviated as BA, commonly involved. Patients may develop hemiplegia, hemianesthesia, homonymous hemanopia, and aphasia. If the vessels of the spinal cord are involved, syphilitic meningomyelitis presents as spastic weakness of the legs, loss of sphincter control, and sensory loss. Parenchymal involvement in the brain manifests as general paresis with features of dementia and psychosis, or in the spinal cord as tabes dorsalis with loss of proprioception and vibratory sense. Diagnosis of neurosyphilis. Diagnosis of neurosyphilis is based on CSF analysis that shows an elevated white blood cell, abbreviated as WBC, count equal to or greater than 5 cells per milliliter with lymphocyte predominance, elevated protein, and a reactive CSF Venereal Disease Research Laboratory, abbreviated as VDRL, test. The sensitivity of CSF VDRL has not been clearly established, and while a positive CSF VDRL confirms neurosyphilis, a negative test does not exclude it. There are no pathognomonic radiological findings, and imaging is of little diagnostic value. Treatment of neurosyphilis. Penicillin is the treatment of choice for neurosyphilis. If the patient is penicillin allergic, desensitization should be performed. Treatment is with aqueous crystalline penicillin G 18 to 24 million units per day intravenously, given either by continuous infusion or as 3 to 4 million units IV every 4 hours for 10 to 14 days. If penicillin cannot be used, then ceftriaxone 2 grams IV or intramuscularly, IM, every 24 hours may be used in non-pregnant patients for 10 to 14 days, although the data on efficacy are limited. We will now progress to neurobrucellosis. Neurobrucellosis is rarely seen in most developed countries, but remains endemic in the Middle East, India, and Latin America. Brucella species are aerobic, intracellular gram-negative cocoa bacilli. 4 pathogenic species, Brucella abortus, Brucella sui, Brucella canis, and Brucella melitensis infect humans. Brucella melitensis is the most pathogenic. Most infections occur secondary to direct exposure to animals or consumption of contaminated animal products including unpasteurized milk. We will now discuss the pathogenesis of neurobrucellosis. Brucellosis occurs following contact with infected animals, unpasteurized milk products, or by inhalation. The bacteria then migrate to lymph nodes and survive intracellularly within macrophages. CNS involvement is mediated both by the direct effect of the bacteria and the resulting immune response. CNS invasion occurs either via transport within macrophages or direct endothelial cell invasion. Brucella invades and replicates within astrocytes and microglia. Activation of the innate immune system triggers an inflammatory response which leads to astroliosis, a characteristic feature of neurobrucellosis. This inflammatory response is primarily responsible for the clinical features of neurobrucellosis. Ischemic stroke results from vascular and perivascular inflammation leading to lacunar infarcts, microhemorrhages, and venous thrombosis. A second mechanism by which stroke may occur is rupture of a mycotic aneurysm. Hydrocephalus may be seen if granulomatous inflammation within the CSF blocks reuptake by the arachnoid villi. And now we will focus on the treatment of neurobrucellosis. Recommended treatment for neurobrucellosis consists of 6 months of antibiotic therapy, which may be extended for a longer duration based on clinical response. Treatment is challenging due to the intracellular nature of the organism. Antibiotics with activity against Brucella include ceftriaxone, rifampin, doxycycline, and aminoglycosides, such as streptomycin and gentamicin. Regimens vary, but typically include multiple agents. The combination of doxycycline 100 mg IV or orally twice daily, rifampin 600 to 900 mg orally daily, and ceftriaxone 2 grams IV every 12 hours is one example. Repeat CSF studies should be performed to confirm normalization as evidence of cure. Pause the video and carefully scrutinize Figure 123.1 MRI images of a 51-year-old woman with neurobrucellosis showing a suprasellar cystine located extra-axial lesion, hypointense on axial T2 weighted and T1 images before advancing to the next slide. Pause the video and carefully scrutinize Figure 123.2 illustrating sagittal T2 weighted image of MRI of the cervical region, showing intradural, extramedullary hypointense nodular lesions, consistent with granuloma formation, in a 21-year-old male with neurobrucellosis and meningitis before advancing to the next slide. We will now progress to neuroborreliosis. Lyme disease, one of the most common tick-borne infections, is caused by Borrelia burgdorferi in the USA and other Borrelia species in Europe and Asia. In the USA, the incidence is highest in the Northeast, Northern Midwest, and occasionally in Northern California. Ixodes scapularis, the deer tick, serves as the vector, with the vast majority of cases occurring in summer months. The nymph stage of the tick is responsible for most human cases, but adult ticks can also transmit the infection. The tick must remain attached for 24 to 48 hours to successfully infect humans. Initial symptoms may include fever, headaches, fatigue, and a characteristic spreading rash called erythema migrans. If untreated, hematogenous dissemination of the spirochetes occurs and may involve the joints, heart, or CNS, resulting in Lyme neuroborreliosis, abbreviated as LNB. Next we will discuss the pathogenesis of neuroborreliosis. After Borrelia burgdorferi enters the host following an infected tick bite, several mechanisms in the pathogenesis of Lyme neuroborreliosis have been proposed. CNS invasion may occur through the bloodstream or along the peripheral nerves. Even though a definite entry of Borrelia has been proven by culture methods and polymerase chain reaction (PCR), the exact mechanism is not yet understood. Borrelial-induced chemokines can be found in high concentrations in the CSF, which may contribute to bacterial migration along the peripheral nerves or lymphatic vessels to the CNS. The spirochetes interact with receptors on glial cells, inducing the production of pro-inflammatory cytokines including interleukin-6 or tumor necrosis factor alpha, TNF-alpha. These cytokines are neurotoxic and may provoke an autoimmune reaction leading to Lyme neuroborreliosis. We will now focus on the clinical features of neuroborreliosis. After an incubation period of about 3 to 32 days, progressive infection from the early localized erythema migrans to late manifestations, including CNS involvement, is seen in patients who have not received antimicrobial therapy. The neurological abnormalities include lymphocytic meningitis, encephalitis, cranial nerve abnormalities, particularly peripheral facial nerve palsy, cerebellar ataxia, radiculoneuritis, and myelitis. A small number of patients present with ischemic stroke secondary to cerebral vasculitis. Stroke can occur several weeks to months after a period of nonspecific symptoms such as headaches and malaise. Lyme neuroborreliosis should be considered as a possible etiology of otherwise unexplained cerebral vasculitis and stroke, particularly when there is a history of tick bites, erythema migrans, facial palsy, or radicular symptoms. And now we will focus on the diagnosis of neuroborreliosis. The diagnosis of Lyme neuroborreliosis relies on the epidemiology, clinical history and examination, CSF analysis, and antibody studies of serum and CSF. Borrelia burgdorferi is a tissue-based organism and does not remain in blood or CSF for prolonged durations. Cultures are not readily available, but serological diagnosis is widely used. The Centers for Disease Control and Prevention, CDC, recommends a two-step process when testing blood for antibodies against this bacterium. ELISA, enzyme-linked immunosorbent assay, is the screening test, and Western blot, abbreviated as WB, is used for confirmation, using the same blood sample. By week 4, the test is positive in 70 to 80% of patients with Lyme infection. CSF analysis shows a lymphocytic pleocytosis, elevated protein content, and normal glucose levels. CSF immunoglobulins IgG, IgM, or Ig are directed against Borrelia burgdorferi may be seen. Lyme antibodies are more often present during acute, rather than chronic neuroborreliosis in the CSF. Imaging with MRI may reveal meningeal enhancement in patients presenting with stroke, suggesting an underlying inflammatory disease. We will now discuss the treatment of neuroborreliosis. Patients with isolated peripheral facial nerve palsies can be treated with oral doxycycline dosed at 100 mg every 12 hours. Amoxicillin, dosed at 500 mg 3 times daily, or cefuroxime, dosed at 500 mg every 12 hours, are reasonable alternatives. If there is a contraindication to therapy with doxycycline, e.g., children less than 8 years of age, pregnant or breastfeeding women, and allergy to tetracycline. Preferred parenteral regimens for patients with neurological abnormalities include ceftriaxone, 2 grams IV daily, or penicillin G, 18 to 24 million units per day in divided doses. A Jarisch-Herxheimer reaction may occur during treatment of any form of Lyme disease. Some patients may experience worsening of symptoms in the initial 24 hours of therapy, resulting from the host's inflammatory reaction to dying spirochetes. Duration of treatment is usually 14 to 28 days and results in significant clinical improvement, even though it may take longer for complete normalization of CSF. And now we will consider the pathogenesis of neurotuberculosis. Mycobacterium tuberculosis, abbreviated as MTB, is an aerobic, non-spore-forming acid-fast bacterium. The pathogenesis involves entry of Mycobacterium tuberculosis into the systemic circulation following an initial pulmonary infection. It subsequently invades the CNS, in which it establishes a focus called rich focus, either in the meninges, subpial, or subependymal region of the brain or spinal cord. This focus may then rupture into the subarachnoid space or ventricular system, causing meningitis. The likelihood of invasion into the CNS depends on the magnitude of bacteremia and the extent of the cell-mediated immune response to the infection. And now we will look at the diagnosis of neurotuberculosis. A positive acid-fast smear or culture for Mycobacterium tuberculosis from a CSF sample is considered the gold standard for definitive diagnosis of neurotuberculosis. CSF analysis shows a lymphocytic pleocytosis. Neutrophilic predominance can be seen early in infection. Elevated protein level, that is greater than 100 mg per deciliter, and low glucose levels. Mycobacterium tuberculosis PCR should be obtained on CSF sample if there is high suspicion. Because of widespread resistance, antibiotic susceptibility testing should be completed on all positive Mycobacterium tuberculosis cultures. The prognostic value of TST, an abbreviation for tuberculin skin test, and IGRA, interferon gamma release assay, in the diagnosis of CNSTB is limited. MRI is the imaging modality of choice and is superior to CT in the evaluation of suspected tuberculous meningitis and its sequelae. Findings include choroid plexus enhancement with ventricular enlargement or thick meningeal enhancement, either of which are highly suggestive of tuberculous meningitis. Cerebral infarcts can be seen in nearly 30% of cases, figures 123.3 and 123.4. Next we will discuss the treatment of neurotuberculosis. CNSTB is associated with significant mortality, and therefore prompt initiation of antimycobacterial therapy is key to survival. For patients, in whom there is strong clinical suspicion based on history, epidemiology, and suggestive CSF findings, treatment should be started while awaiting results of specific diagnostic tests. Rifampin or rifabutin, isoniazid, INH, pyrazinamide, PZA, and ethambutol constitute first-line therapy. Isoniazid and pyrazinamide have excellent CNS penetration and should always be included as part of the antimycobacterial regimen. After the initial 2 months of combination therapy with 4 drugs, Their escalation to rifampin and isoniazid for the remainder of the treatment course is recommended, once the susceptibility of the isolate to both of those drugs is confirmed. Given the risk of optic neuritis with ethambutol, baseline ophthalmological examination should be completed for patients starting this drug. Vitamin B6 should be administered with isoniazid to prevent peripheral neuropathy, and liver function tests should be monitored. Second-line agents include ethionamide, cycloserine, kanamycin, capreomycin, and para-amino-salicylic acid, but are considered less efficacious and associated with greater toxicity. High-dose corticosteroids should be used as adjunctive therapy and have shown benefit in treatment of CNS TB. Pause the video and carefully scrutinize Figure 123.3 illustrating cranial MRI and MR angiography of a 32-year-old woman with Stage 3 tuberculous meningitis before advancing to the next slide. Pause the video and carefully scrutinize Figure 123.4 illustrating cranial MRI and MR angiography of a 30-year-old man with Stage 3 meningitis showing multiple infarcts involving both the basal ganglia and left cortical infarction on the middle cerebral arterial territory on both T2, that is Part A, and diffusion-weighted imaging, that is B, before advancing to the next slide. And now we will shift gears to neuroinvasive listeriosis. Listeriosis is a zoonotic infection caused by a gram-positive, facultatively anaerobic, intracellular bacterium called Listeria monocytogenes. Invasive disease including meningitis, encephalitis, or bacteremia may occur in the immunosuppressed host. The mean incubation period for neuroinvasive disease is about 31 days, and differs significantly for Listeria monocytogenes-induced gastroenteritis, about 24 hours. The most common CNS manifestation of Listeria monocytogenes is meningoencephalitis. Brain abscess, cerebritis, and rhomboencephalitis are rare but serious complications and associated with significant mortality. Ingestion of contaminated food appears to be the most common route of transmission of Listeria monocytogenes. And now we will look at the pathogenesis of neuroinvasive listeriosis. Listeria monocytogenes possesses an affinity to cause CNS infections, mainly involving the brain stem and meninges in persons with deficiencies in cell-mediated immunity. This, combined with the ability of the organism to penetrate the blood-brain barrier, accounts for its virulence. Invasion of the CNS may occur via a hematogenous route, within circulating leukocytes, or via a neural route in which bacteria penetrate into oral tissue, are phagocytosed by tissue macrophages, and then invade the cranial nerves. They reach the CNS by moving in retrograde direction through nerve axons, followed by their spread intracellularly to the brain parenchyma, resulting in clinical rhomboencephalitis. Next we will look at the clinical features of neuroinvasive listeriosis. Patients with Listeria monocytogenes meningitis often have a subacute clinical presentation. Fever, nausea, headaches, and stiff neck occur in majority of the patients. Focal neurological deficits, fluctuating mental status, ataxia, or seizures are indicative of parenchymal involvement and subsequent meningoencephalitis. Brainstem involvement with Listeria monocytogenes results in rhomboencephalitis. Patients initially present with nausea, vomiting, headaches, and fever with progressive development of signs and symptoms of stroke, including asymmetrical cranial nerve deficits, cerebellar signs, hemiparesis, or hemisensory deficits. Rhomboencephalitis due to Listeria monocytogenes is associated with high mortality and devastating neurological sequelae. Next we will look at the diagnosis of neuroinvasive listeriosis. Isolation of Listeria monocytogenes from blood, CSF, or an otherwise sterile site is required for diagnosis. CSF analysis reveals elevated WBC count and a neutrophilic pleocytosis. Protein levels are elevated and glucose level is often low. Gram stain of the CSF may be negative in about 2/3 of patients and blood cultures are positive in only 50%, which makes it extremely challenging to make a definitive diagnosis upon initial presentation. MRI of the brain is considered superior to CT scan, especially in the setting of brainstem involvement with rhomboencephalitis. Finally, we will focus on the treatment neuroinvasive listeriosis. Empiric therapy for meningitis in immunosuppressed patients should target L monocytogenes, if the clinical suspicion is high. Ampicillin and penicillin G are considered the drug of choice. Combination therapy with IV gentamicin to achieve synergy is often used. Adjuvant steroid therapy has failed to demonstrate favorable outcomes or improve mortality, morbidity. Trimethoprim sulfamethoxazole is considered an alternative in patients with severe penicillin allergy. Duration of treatment largely depends on the degree of CNS involvement. Meningitis should be treated for at least 21 days, and brain abscess and rhomboencephalitis should be treated for about 6 weeks, depending on the clinical and radiographic resolution of infection. Thank you.